I'm going to start really quick with the disclosure so that we have that out of the way. So this is part of the MAVEN accreditation project. So none of the individuals in this presentation are in a position to influence the content for this educational activity, or do they have any relevant financial relationships to disclose with ineligible companies for marketing, selling, reselling, or distributing healthcare products used for or by patients. And the other is that we have the ACGME accreditation, like I already mentioned, and you will potentially get as much as one CME credit. And that is all I've got. So with that, Dr. Sadur, I want to just say a little bit about your bio. Dr. Craig Sadur was an assistant professor in medicine at the University of Colorado Health Sciences Center and chief of the endocrine unit at the Denver General Hospital. After 9 years of private practice in endocrinology, he joined the Kaiser Permanente, Northern California, where he practiced clinical endocrinology for over 24 years and received the Career of Caring Award for exemplary physicians. And I realized I read the slides, but I didn't show them off, so I'm not very cool.
That's okay.
Really quick. And then I promise, Dr. Sadur, I'll give it over. So these are just the quick disclosure slides to make sure that we show them. And then with that, Dr. Sadur, I will send it over to you.
Okay. Right. Thank you so much, Dr. Feldstein. And with that, I am trying to get to my slideshow.
I wonder, Dr. Sadur, could I get a show of hands? I'm having a hard time hearing you, and I know we've had
I can hear
with the
him.
audio. Can everybody hear?
Yes, I can hear him.
Okay. Okay. Never mind. Sorry, just me then. Thank you, Dr.
Okay.
Sadur.
All right. Yeah, if there's any trouble hearing me, let me know. But thank you very much, Dr. Feldstein, and thank you, Kristen Talbot, and thank you, Jonathan Lewis, our IT person, and thank everyone for being here. So today, as you heard, we're going to talk about Weird Thyroid Lab Results. And with that, the objectives for today's educational session are to recognize how those weird thyroid lab results might look, and then to review their possible causes, and then to learn the workup that's needed. So here's the thyroid gland. As we know, it's small but mighty and takes on a lot of different roles, and we're going to dive into those. So there's the thyroid function test results, and most of the time, fortunately for the patients, almost all patients and almost all of us clinicians, they look straightforward, as we expect. However, a minority look weird, and by weird, an example would be a discordant component. So you get your thyroid panel of your T4, maybe your T3, and your TSH, and they don't look aligned. They don't look like we think that they should. So within the thyroid panel, there is something unusual. And then sometimes they look strange because they conflict with the clinical picture. So the panel in and of itself may look fine, but when you look at the patient and take it in context with the thyroid panel, something's strange. It just doesn't fit. So let's go into this. And this is the classic hypothalamic pituitary thyroid axis we've seen. So we've got our hypothalamus that puts out thyrotropin releasing hormone, and it stimulates the anterior pituitary gland that puts out thyrotropin, also known as thyroid stimulating hormone, and that circulates to the thyroid gland to stimulate secretion of thyroid hormones, mostly T4, but some T3. Most of the T3 in the blood system is from T4 to T3 conversion in the periphery. And these hormones have a very important role for the homeostasis. So they go back and have negative input to the pituitary and the hypothalamus. So it keeps this whole system in check, and it keeps it so that the levels for almost all of us stay within normal range, not too high, not too low. Let's dive into the cases. So case number one, we've got a 23-year-old female with repeated nausea and vomiting. On physical examination, she's clinically euthyroid. She does not have a goiter. Labs are drawn. She has a high total T4, a high total T3. Her normal, she has normal levels for free T4 and normal free T3, and her TSH, or thyroid stimulating hormone, is low. So right away, this looks weird because she's clinically euthyroid. She doesn't have a goiter. We would expect normal thyroid function tests, but she has high total T4, high total T3, normal free T4, normal free T3. And so it's discordant within this thyroid blood system, and her TSH is low. So something is going on. And pretend she's your patient. Pretend she's in your clinic or she's on telemedicine with you. Think to yourself, okay, we've got something that doesn't fit. Clinically euthyroid, no goiter, her lab tests are off. What's the next test that you might consider ordering? Well, a pregnancy test. And it turns out pregnancy has quite a bit of effect on our thyroid hormone panels and lab results. So with pregnancy, you can get high total T4 and total T3 and a low TSH. In fact, the total T4 may be, depending on when during gestation, up to 1.5 times the upper limit of normal for what has been shown to be normal in non-pregnant people. So low TSH transiently occurs in 10 to 20% of pregnant women, and it's often associated with a high total T4, like I mentioned, and high total T3, but usually a normal free T4 and free T3. Keyword usually, not always, but usually. So it's important to have trimester-specific normal ranges. So what's considered normal in pregnancy is abnormal for those who are not pregnant, and during pregnancy there are changes. So hopefully your lab has the normal range for non-pregnant patients, but also trimester-specific normal ranges for pregnant patients. So there's the human chorionic gonadotropin-mediated thyrotoxicosis. So women are pregnant, have their placenta putting out hormone, and commonly there's this gestational transient thyrotoxicosis, and it tends to be late first trimester, but you can get it a little off in different times. There's hyperemesis gravidarum that is frequently associated with abnormal thyroid blood tests, usually does not need specific anti-thyroid treatment, but it's there associated, and with the eventual, hopefully soon for the patient, resolution of the hyperemesis state, you expect an improvement in the thyroid panel results. And there are the rarer but serious trophoblastic hyperthyroidism, chorionic tumors. So the differential diagnosis for high free T4 and T3 and low TSH would be the following. The primary hyperthyroid states, the most common would be Graves', which is part of autoimmune thyroid disease. Part of that spectrum is Hashimoto's, where most Hashimoto's patients are not hyperthyroid, but a minority are in what's been nicknamed Hashitoxicosis. You can have non-diffuse hyperthyroidism with toxic multinodular goiter, or if you have a solitary autonomous nodule, a toxic adenoma. So these are the primary hyperthyroid states. The thyroid gland is off to the races. It's hypersecreting thyroid hormone, and the anterior pituitary is responding appropriately by inhibition. You get the high thyroid hormone levels and the low TSH. But you can also get this panel pattern with thyroiditis, and it occurs from various causes. The most common is subacute thyroiditis, but there is also a phenomenon of postpartum thyroiditis, and there's other rare kinds of inflammation of the thyroid that causes this transient destruction of the thyroid tissue, where you get this release of thyroid hormone into the blood system. And you can have thyroxine, L-thyroxine treatment, and that would be over treated. Sometimes patients may do it factitiously, but it may be that that dose for that patient is too much. And then you get this elevated T4 level and you get the TSH low. T3 should be normal in that situation. And various drugs, including amiodarone, to name one, can adversely affect the thyroid panel. So it's always good to know what the patient is taking. And jod-basedow with excessive iodine intake. Jod-basedow literally means in German, iodine-induced Graves' disease. So there are very well-meaning patients who have done their reading, looked on the internet, find out that iodine is an important component of thyroid hormone function, but unfortunately, they may be taking an excessive amount and it can backfire. For a lot of patients who may have an underlying thyroid defect that wouldn't manifest unless they're taking excessive iodine, that can show up with abnormal clinical situation as well as lab test. And pregnancy related. And struma ovaria, an ovarian tumor, very rare, but you can get that as the culprit for the hyperthyroidism. Okay, let's do a second case. So we have a 74-year-old male post-hospital discharge. And on exam, he's clinically thyroid, no goiter, just like our first patient. His labs are abnormal, but in a different direction. He's got a low free thyroxine. He's got a low total T3 and he's got a low TSH. So that's the weirdness. As we saw, if you have underactive thyroid, then you have less thyroid hormone feeding back to the anterior pituitary, which should be high in TSH. So something's going on. And so think again, pretend he's your patient. What might you want to order? Well, one thing that would be helpful would be hospital records, because you can get a lot of important information. Remember, he was just discharged from the hospital. And this is a picture of the old Los Angeles County University of Southern California Medical Center. Fun fact, for years, it's been shown in the soap opera General Hospital as the hospital that they have. Okay. So back to this patient, you get the hospital record, you go through it and it's like, whoa, he unfortunately had severe pneumonia. It was so bad he had to be intubated and he had to be on ventilator support. He's not yet back to baseline, but fortunately he's improved and he's on no offending medicines. So what might be affecting his thyroid function? And with this clinical scenario, what looks most likely is non-thyroidal illness. So when he's going through his life, doing okay, functioning fine, his thyroid gland's doing its job. It's secreting thyroid hormone. It's circulating throughout the body. He's got normal T4, normal T3, his TSH is normal. But if he has these non-thyroidal illnesses, and this gentleman suffered a terrible pneumonia, hospitalized on a ventilator, the thyroid panel becomes abnormal. And typically these patients don't need thyroid treatment, but it's important to monitor them to make sure they normalize once their underlying illness is resolved. Okay, so case number 3. We've got a 29-year-old male who presents with fatigue, weight gain, cold intolerance, constipation. And you take your past medical history, and he had a motor vehicle accident and suffered a skull fracture 9 months before you see him. Otherwise, he's healthy. And on physical exam, unlike the first 2 patients, he's clinically hypothyroid, but he doesn't have a goiter. And you do your lab test, and you look back, and the free T4 and the TSH were normal 3 months ago, but now they're both low. So things are weird. He's clinically hypothyroid, but he doesn't have a goiter. That's not, unheard of, but it still makes you wonder what may be going on. And his thyroid levels recently, 3 months ago, were fine, and now they're both low. So why might his thyroid function tests have changed? Something's going on, and it may be what's in his brain. So there's traumatic brain injury, and it can cause both anterior and posterior pituitary deficiencies acutely and chronically, and his is a chronic effect. It's more likely to be anterior, but posterior pituitary deficiencies can occur. And if you look at the different anterior pituitary hormones, the most common one that's deficient in patients with traumatic brain injury is growth hormone. But you can get adrenal, in this case, thyroid, gonadal, and vasopressin deficiencies have occurred. So it's always nice to know in your patient who has unusual thyroid levels, have you suffered a significant head trauma? And it could be not the thyroid gland, that's the problem, but what's happening superiorly. So the differential diagnosis for low free thyroxine T3 and a normal or low TSH would be non-thyroidal illness. Again, something's going on, throwing the monkey wrench into the thyroid system. Secondary hypothyroidism, that's what this gentleman has suffered. So his thyroid gland is fine. His thyroid gland's waiting for the signal that should be coming from the hypothalamic pituitary system. And it either doesn't come or it's underproduced. So the thyroid gland is relatively idle compared to how it's usually stimulated. So the traumatic brain injury is just one potential cause. You can have pituitary disease. You can have a variety of hypothalamic pituitary disorders. It can be infection, it can be vascular, it can be neoplastic, but something's coming from hypothalamic pituitary system. And lab assay interference, that's always a possibility in this thyroid panel situation. Case number 4, 50-year-old female. She has a known history of hypothyroidism. She's on L-thyroxine 0.3 milligrams a day. On physical exam, she's clinically hyperthyroid. She's got a small diffuse goiter. You run the labs, her free thyroxine is high and her TSH is high. So you look at this, and the first thing that should attract your attention is this dose of L-thyroxine 0.3 milligrams a day. The average dose for someone like her would be about 110 micrograms a day. This patient's on 300 micrograms a day. So if you look at the normal distribution of how much thyroid hormone dose would normalize a patient's thyroid levels, she would be way off to one side of the curve. On a physical exam, with this dose, no surprise that she's clinically hyperthyroid. And with her history of hypothyroidism, no surprise she's got a small diffuse goiter. And you run the labs, no surprise she's got a high free thyroxine, and that goes along. But she's got a high TSH, and that is a surprise. And that's how her lab results look weird. That's the one piece in this that doesn't fit. So what do you ask her? Something's going on. And what would be helpful is to ask her about her medicines. So there's a possible medical adherence issue. And it's always nice to know with what you're dealing when you see a patient who has strange thyroid labs in terms of what's going on with their medicines. And as we've all seen, medication adherence is difficult. It's challenging. I mean, for any of us who have had to take a medicine on a regular basis, it's not unusual to miss a dose or some. So a lot of patients may feel bad about that. And one thing for you to consider is a possible question. And that question would be empathizing with the patient. It's difficult to take a pill every single day. How many days in a week do you miss a pill? And the answer you may get would be, well, you know something? I definitely make sure I take it 4 days a week. And if it's taken it 4 days a week, you're missing almost half the doses. And it's nice for us to know with what we're dealing. And that takes a lot of the mystery out of the clinical picture in the lab panel that don't jive. So by asking a question like this, you're almost creating a third party. There's the patient, the first party, you're the second party, and the pills are the third party, trying to take away blame and shame and such, because it is difficult, and trying to find out and then taking steps to help the patient. So with variable and poor adherence, the free thyroxine levels change before the TSH corrects. So that's why you can get this discordance. So maybe the patient started taking her medicine shortly before labs were drawn. She hasn't been on the medicines regularly. She didn't have enough time for a steady state. And she knows that you ordered the lab test. And it's like, oh my gosh, I better start taking the medicine, sort of like cramming for the exam. And if that's the case, the free thyroxine normalizes sooner than the TSH. So with her 0.3 milligram a day, she's on too much. And that's why the free thyroxine was high, indicating her dose is beyond what she should be. But the TSH, the anterior pituitary, the TSH didn't have time to bring that level down to normal. So that's the kind of scenario you get when a patient has had poor adherence, start taking the medicine of what's too high, and you get those strange lab tests. Now, one pragmatic issue is when you see a patient with this, medical adherence may be an issue, but the differential diagnosis for high free thyroxine T3 with normal or high TSH actually has a little more. We've already talked about the L-thyroxine decreased adherence with the recent administration. In other words, hasn't been taking it regularly, boom, starts taking it, and the labs show the high free T4 and the not yet normalized TSH. But there's drugs that can do it. We see a lot of patients on seizure meds like Dilantin. There's patients who could be on heparin for whatever reason, and amiodarone, again, commonly affects thyroid panel tests. And there's the non-thyroidal illness. Now, we had our gentleman who had this severe medical problem. He had the pneumonia with the respiratory failure. But you can get it also from psychiatric. So if you have a patient who's had psychotic break, let's say needed inpatient, it's not uncommon for thyroid levels to look abnormal. And again, they typically don't need thyroid hormone adjustment with treatment, but you want to follow them along, and hopefully the psychiatric illness will improve and you can retest, and often you see normalization of thyroid panel. Lab assay interference is certainly possible. And rarely, now we're talking the rare things. There's TSH producing pituitary adenoma that's overproducing TSH. The thyroid gland is dutifully responding to that increased stimulation. There's thyroid hormone resistance, also very rare. Thyroxine variant, rare. And there's a neonatal. But most of what you're going to see are in these top 4 reasons. Okay. So the lab is important. And the abnormality you see in the lab panel actually may be coming from the laboratory itself and not something inside the patient. So with that, there are lab assay interference next steps. And those would be communicating with the lab director that the patient needs the following. So if the T4 looks strange, it can be done using equilibrium dialysis or mass spectrometry. And if the TSH looks odd, it can be done using a different antibody pairs methodology or immunosubtraction using polyethylene glycol or protein G/A. For all of us who don't deal with this all the time, you look at that and you go, wow, that's really not something I think about all the time. But fortunately, the lab director does think about it. So if you're getting something odd and you've looked at everything else and you go, this could be a lab assay interference issue, reach out to the lab director and he or she should know what to do. I mean, equilibrium dialysis, oh yeah, mass spec, we do that all the time. Polyethylene glycol, yeah, we've got the capability. So they're the ones that can do that. Okay, case number 5. We've got a 31-year-old male who's 4 weeks following an upper respiratory tract infection. In the past, recently, he had this anterior neck pain and tenderness, but fortunately that resolved. And now he's got symptoms of mild hypothyroidism. You do your exam, and similar to his symptoms on exam, he appears to be mildly hypothyroid, and he has a small diffuse non-tender gland. And you do your labs, and his free thyroxine is low, his total T3 is low, his TSH is high. So he had a recent infection. He was doing worse clinically. He's doing better. He's still not normal. He's got tests that show this. So what medicine do you prescribe? And the answer would be usually none. And it turns out he's got a classic picture of subacute thyroiditis. And typically it's 1 to 3 weeks following the antecedent upper respiratory tract infection with pain and tenderness in his gland. It has a triphasic response. Initially, the labs are hyperthyroid, then they go through a hypothyroid phase, and almost always they end up biochemically euthyroid. So it matters when you test him, when you catch what phase he is in. Now, for symptoms, for some of the patients who have symptomatic hyperthyroid complaints, you could give a beta blocker transiently just to get them through that period. If patients are having a lot of pain and tenderness, what's generally the go-to medicine is a non-steroidal anti-inflammatory drug. Even though glucocorticoids can be given, it's rare that they're needed. They're just, more potent anti-inflammatory. And again, the treatment is usually self-limited according to symptoms. Hypothyroidism typically does not need thyroid hormone replacement treatment. They usually don't get very hypothyroid, and they're not going to be hypothyroid for long. But you do want to monitor them to make sure they normalize and end up biochemically euthyroid. So here's a graph, and it shows the phases: thyrotoxic, hypothyroid, euthyroid. So early on, you've got a high T4, you've got a suppressed TSH. And if you were to do the radioactive iodine uptake, which usually is not needed, it's suppressed. And then the hypothyroid, you get the plummeting of the T4, you get the raising of the TSH because it's responding appropriately to the low T4. And if you were to do the radioactive iodine uptake, it's going away from its suppressed state. And then euthyroid, they should end up with normal T4 and TSH. So the differential diagnosis for low T4, T3, and high TSH is all those things that cause primary hypothyroidism or thyroid gland failure. The most common in this country is Hashimoto's thyroiditis, which is an autoimmune disorder where the body's immune system goes after the thyroid and really knocks it down. And patients have had radioactive iodine treatment, and that can be either from treatment for hyperthyroidism or an autonomous nodule, or if they've had thyroid cancer. Post-thyroidectomy, so post-operatively, again, with our thyroid cancer patients, we're intending to make them hypothyroid for total thyroidectomies. Neck irradiation. So if you had a patient, let's say who's had Hodgkin's lymphoma and needed the field that would be pinching upon the anterior neck, that patient could end up with a primary hypothyroidism. And there's various infiltrative diseases, infections, tuberculosis, deep fungal, sarcoidosis, tumors. Those are possible. They're rarer, but down the list, but still on the list. Hypothyroid phase of the subacute thyroiditis, like this gentleman we just saw who had that. And there's various drugs. Lithium can cause that. It affects thyroids. Iodine excess or deficiency. Deficiency is, we don't expect this in people who have grown up in our country, but it's very common in other parts of the world. So it could be one airplane ride away from someone being in your clinic who has iodine deficiency, but iodine excess, well-meaning patients can find themselves in that situation. Rydell's thyroiditis, a fibrous infiltrate, very rare, and congenital hypothyroidism. Okay, so case number 6. 42-year-old female. She has a history of hypothyroidism and hair thinning. She's had variable TSH levels on the L-thyroxine treatment, and her adherence is excellent with the medication. And she says she's into vitamins. And on exam, she's clinically euthyroid. You've been doing labs on her, and they're all over the place. Her TSH sometimes is high, sometimes it's low, sometimes it's normal, and it doesn't fit a pattern. So in that case, it's weird. So with the thyroxine schedule factors, they include if the patient's taking thyroxine with supplements. And by supplements, it's important to find out what do they take that's over the counter, either recently or currently. And hair thinning is an issue that many patients understandably want to treat on their own. So there's biotin. And it's a supplement that's given for people with thinning hair. And it affects the lab assays. This is part of the lab assay interference. They get a falsely low TSH, depending on what the assay is, and they get falsely high free T4 and T3. So we can be fooled with this by looking at it and going, you don't look like this, but your labs do. Well, it turns out they don't have to stop biotin, but if they could avoid it for 3 days before the blood collection. Iodine's another culprit, because again, a lot of patients trying to do well, feel better, help their thyroid, will take iodine. And there's various sources that people can get iodine into their system. You can get it orally through different meds. Amiodarone, again, is loaded with iodine. But if they need that for their arrhythmia, then, it's possible to work around it. If cardiology can give some other medicine that would do the same benefit for the antiarrhythmia, that would be optimal. Supplements such as kelp, seaweed, a lot of patients take these regularly. Selecine, an anti-cellulite supplement. It can be vaginal with douches, and you get absorption of iodine that then goes systemically and affects the thyroid. Infusions, such as cardiac catheterization or radiographic contrast. Think back to the second patient we had who had the non-thyroidal illness, and he was in the hospital severely ill with his respiratory failure. Commonly, patients who have had these long, difficult illnesses that go on for weeks to months, commonly someone has infused them with iodine for very good reasons, because you're trying to image something that needs attention. But another way to think of hospitals are they're big buildings with lots of iodine in them. And when you find out that a patient within the relatively recent past has had infusion of iodine, it can affect the thyroid panel and even the clinical picture of thyroid for weeks, if not months. And topically, patients can take the medicine on their skin, they get absorption, and it can affect. So for chronic topical, you can get effects. Okay. Case number 7. This is a 75-year-old female with hypothyroidism and rheumatoid arthritis, and she's on L-thyroxine with good adherence. And on physical exam, she's clinically euthyroid. She has a small diffuse goiter. So clinically, looks like things are good. You're on a medicine that doesn't strike you on exam as being too high, too low. Small diffuse goiter, she's known to have hypothyroidism. You do your lab test, your free T4, T3 are fine, but your TSH is low. So what do you want to ask her? Well, about the other medicine she takes. Some medicines decrease TSH secretion, like glucocorticoids and opioids. She's got rheumatoid arthritis. Maybe she needs chronic glucocorticoid therapy. And we do see TSH decrease in those patients. And with patients who are on opioids, it's common for the opioids to affect the hypothalamic pituitary axis. So TSH is decreased. So the differential diagnosis for a normal free T4, T3, and a low TSH, over replacement for the L-thyroxine. So if everything is, simple, and you find out that the TSH is low, it's best to lower the thyroxine level. It's not good for patients to be chronically hyperthyroid. The demographic for hypothyroid, we see it in women more than men. Thyroid disease commonly is more common in women than men, but we do see it in men. And who's the demographic that's most likely to have osteoporosis? Women. We do see it in men, but women tend to get it earlier in life. So it's been shown that over replacement increases bone resorption, and you get lower bone mineral density, and it puts patients at higher risk for developing osteoporosis. Also, arrhythmias, cardiac arrhythmias, commonly atrial. We've seen patients who developed atrial fibrillation that's associated with hyperthyroidism, and it can be this relatively subtle hyperthyroidism with a low TSH. That's what cardiologists look for early when you get a patient who shows up with atrial arrhythmias. How are the thyroid levels looking? Subclinical hyperthyroid, so those are patients not on treatment. Their TSH is low, their free T4, T3 are fine, but they're slightly overactive, and that's a whole other area. What do you do with those patients? Recent treatment for hyperthyroidism. The anti-thyroid meds, or let's say radioactive iodine, is getting the free T4 down, but the TSH hasn't had time to come out of that inhibition by putting out the normal amount from the anterior pituitary gland. Various drugs such as glucocorticoids, like we talked about. Non-thyroidal illness, again, find out what's been going on with the patient. Has there been a big infection? Was there a major stroke or something that has potentially played a role in the thyroid panel? Lab assay interference, we talked about. So here are the things that are the most common. So you get your pituitary and your thyroid gland. Your thyroid gland puts out T4 that inhibits the anterior pituitary, that's putting out TSH, and everything's working well. And you've got normal levels. You get your hyperthyroid patient, and this patient, for diagram purposes, is overproducing from the thyroid gland, and you've got an increased amount. So the anterior pituitary understandably wants to inhibit by putting out less thyroid stimulating hormone. And typically your lab, you're going to get a high T4 and a low TSH. That's not strange. And then you get your primary hypothyroidism, where you get a failing thyroid gland that sends out less signal back to the anterior pituitary that goes, whoa, I've got more work to do, puts out more TSH to try and basically stimulate that failing thyroid gland. So you get this high TSH, low T4. And the secondary, like the patient we have with the brain injury, you've got a thyroid gland that could just be sitting here ready to get the signals to put out thyroid hormone, but it doesn't get the signal, or it gets too little of the signal from the anterior pituitary. So things are just underactive because of what's happening in the brain, and you get the low T4 TSH. Okay, so case 8, let's put a lot of this together. Let's go through this. You have a 38-year-old female, and she's hypothyroid. And in the past, she's had stable TSH levels on thyroid replacement therapy. And every year you see her, every year she looks good. Every year you do your TSH, it's normal. Until recently, TSH levels are high despite increasing doses. So let's say she was on 0.1 milligram a day and her TSH is now high. So you increase it to, I don't know, 0.112. It's still high. You increase it to 0.125. It's still high. You know, it's like, what is going on? She was stable and now this. Well, you ask her a little more. And she started this new L-thyroxine brand due to formulary changes. Very common. Insurance says, you know, we're not going to cover this brand. We're going to cover that brand. Okay. But she's on the same dose. And she needs to take a proton pump inhibitor because of her dyspepsia. She gets a new job and her schedule's changed. Now she's got to start early. And to her credit, she's still finds time to make sure she eats breakfast before she runs out the door. And she is taking her medicines. Her adherence is good. She's taken all her medicine, vitamins at that time, and boom, she's out the door. You do a review of systems. She's been losing weight. Her breasts are tender. She's got secondary amenorrhea. She's got diarrhea with profuse pale stools. She's got increased stress, understandable new job, crazy schedule. She's on the run. And she admits at times she forgets appointments. Okay, so let's see how this may apply to her thyroid levels. So she was hypothyroid. Is hypothyroid. Her TSH was once stable, but now her labs are abnormal. Consider every step along the administrative and metabolic pathways. And by that, there could be a prescription error. Back in the days when we used to write it out, we could have written it wrong. There's cases where pharmacists looked at handwriting of whoever wrote the prescription and made a mistake because of the legibility. You could have typed something wrong, or you could have done everything right, and the pharmacist could have made an error. So there's that possibility. Formulation change. Brand is not necessarily the same as generic. Generic is not necessarily the same as another generic. Patient adherence. Patient could be taking it differently. Absorption issues. How well is it, thyroxine getting absorbed in the gut? Metabolic changes. And if you were to check a free thyroxine index, which is not a recommended screen test, but let's say it comes up high, the best time to check it is at least 4, if not greater than 8 hours after the pill's taken, because you get this transient elevation after ingestion of the pill and then goes down. So with this patient who had normal TSH levels on replacement therapy, and now she's running consistently high, why did her hypothyroidism treatment appear to destabilize? Well, she's got a new L-thyroxine brand. And even if she went from 0.1 to 0.1, from one pill to another, they've done the studies, and the bioassays are a 0.1 milligram pill may not be exactly 100 micrograms. Maybe it's 92, or maybe it's 105. And that's why brand, whatever the patient's taking, if they change from one brand to another, or brand to generic, or generic to generic, wait 6 to 8 weeks and recheck it, because you may need to adjust the dose with fine tuning. PPIs decrease L-thyroxine absorption, and she's taken them together with her thyroxine. L-thyroxine, if taken with foods as well as other agents, it has slower absorption. And she has a busy schedule. Now she's taken all her meds and vitamins together with her breakfast before she heads out to work. Weight loss, diarrhea, maybe she's got malabsorption. She could have celiac disease, and then she's not absorbing the thyroxine at the rate she used to. Tender breasts, amenorrhea, maybe she's pregnant. It turns out that for women who are on stable doses of thyroxine, once they find out that they're pregnant, empirically, it's worth increasing the thyroxine dose by 25 to 50 micrograms a day, and then rechecking the free T4 and TSH 4 weeks later. So we know through the studies that women during pregnancy have a higher thyroid hormone replacement requirement. And you want to monitor them closely during gestation, and then postpartum, go back down to the pre-gestation treatment, and then 6 weeks later, check your TSH free T4. So pregnancy changes physiology. Thyroid is just one of the areas, but it's definitely a factor. Forgetting things. She admits, life's harder. She's forgetting appointments. Maybe there's an adherence issue. So the best way to take L-thyroxine is this way. Take it in the morning, fasting, and 1 hour before taking any of the following. Things like iron, which could be separate or in a multivitamin, calcium, like in Tums, vitamins, fiber, coffee, lovastatin, a little controversial, but who knows, maybe. Magnesium, PPIs, propranolol, raloxifene, soy. And also some things, we don't necessarily think about resin, an old-time cholesterol-lowering meds. If the patient has renal insufficiency, phosphate blockers, carafate, sucralfate for dyspepsia. There are patients who are taking chromium, Caxolate unusual, Orlistat, now one of the meds listed for medical management of obesity. And feel free, because you're going to get these slides from Dr. Feldstein, but feel free to copy and paste onto a paper or something you put in the computer that will be available for patients. Most patients can do fine with this. But there's some patients that taking in the morning is too challenging. And that might be for this patient because of her crazy schedule. She's trying to keep it all together by getting some sleep and getting out the door. If that's the case, they could take thyroxine at bedtime. It's not optimal, but it's reasonable. It's better than missing it. And if they do, they should take it about 2 hours after eating, so that you don't have to worry about interference. And same thing with any of these potentially affecting drugs. So the classes of weird thyroid blood result causes would be intercurrent illness, medications, poor adherence with L-thyroxine treatment, laboratory interference for thyroid hormone and/or TSH measurement, and rarely genetic or acquired disorders of hypothalamic pituitary thyroid axis. So if the clinical picture and lab results misalign, at times the next best step after you've exhausted everything else is to ask the lab to run other assays for thyroid hormones, TSH, or both. And they know how to do this. So in summary, clinical suspicion is key. You want to start there and go, this looks strange. What's going on? Consider variable medication adherence, possible interfering substances. Maybe there's been an intercurrent illness, other drug effects, and the lab could run other assays for thyroid hormone, TSH, or both. And other causes are possible, but fortunately they're rare. So in conclusion, strange appearing thyroid function test results occur at times, and consideration of various causes can be sorted out by practical approach and lead to the correct diagnoses. This is just something to bring to your awareness. The Endocrine Society has these free, always nice, free clinical practice guideline mobile app you can put on your smartphone. It doesn't have any thyroid yet. I think there will be at some point, but it's got things like osteoporosis, diabetes, etc. So it's really helpful. And resources for this talk, there's a couple of sources regarding the odd tests, and the American Thyroid Association has their guidelines that they update periodically. Special thanks to Dr. Feldstein, who took time out and put in all the effort to be the moderator, to Kristen Talbot, our program manager, who puts things together, to Dr. Jill Einstein, our Senior Director of Physician Engagement, our IT coordinator, Shirley Severe Talon, and Jonathan Lewis. Jonathan Lewis, special kudos. We had audio problems at the top of the hour, and he came in like Batman. I'm Robin. He's the one that solved the day. So thank you, Jonathan. This is a picture of Shenandoah National Park during fall foliage. And with that, let me open it up to questions.
Thank you so much, Dr. Sadur. That was really, really great. What a beautiful picture. And also, yeah, Jonathan really saved the day. So just looking at the chat, says one of our learners said, it has become almost a reflex to order T3 along with free T4, but it is rarely helpful. What are the specific indications for getting a T3?
Yeah,
Total
what a
or free?
Yeah, what a practical point. You know, you always like to do the least amount that's absolutely needed to get what you need. So if you're just, for most patients, you go, I don't think this patient's hypothyroid, but I want to make sure doing a TSH alone should be fine. If you have a higher index of suspicion, you're going to look at a TSH, and if it looks like they're still hypothyroid, you want to do a free thyroxine. But T3 really doesn't have a place in hypothyroidism. It does have a place in hyperthyroidism. So again, if you get your TSH and it's low, you know, common things being common, it's usually hyperthyroid, but as we've seen in this talk, it could be something else. You do your free thyroxine, and it usually, if they're hyperthyroid, will be high, but not always. And if that's the case, then you definitely want to do a T3, and the T3 could be elevated where the free thyroxine is normal and the TSH is low, and that's an entity called T3 toxicosis. So for whatever reason, the thyroid gland preferentially secretes T3 instead of T4. And so you do have your thyrotoxic state. And as you mentioned, you could get total or free. As it turns out, this is a lab phenomenon. The total T3 tends to be a little more reproducible, a little more less variable than the free thyroxine, than the free T3. So given the choice, I would do the total T3, but it's not wrong to do a free T3.
So really, thank you very much. And I think that gets to the other question, which is when to order total T3 and total thyroxine. Another one, oh, this is a good question. For shift workers, do you recommend taking their thyroid supplement before waking, or is it better in the morning or regularly? Or how do you tell shift workers to take their thyroid, their T4, and then also when their shifts change?
What a great practical point. So the biggest challenge always is people who have changing shifts. The main thing with thyroid is you want to make sure they're taking the medicine every day, and that ideally they be fasting and an hour before those interfering substances. So I would, ask the patient, but when he or she is waking up from when they sleep and eating their first meal of the day, which could be any hours of the day, then to treat it like it's the morning and go ahead and take your thyroid medicine, wait an hour for eating and such. The bigger challenge, parenthetically, is glucocorticoids. So they make thyroid look easy in this case.
Yeah, for sure. I think we've got the questions that I can see. I wonder, one of the things, I just wonder if you could help clarify. This is just for me. I'm just wondering, you went over the issues that can happen during pregnancy with your thyroid. So many of our clinicians are providing a degree of obstetric care at times. So how often is it recommended for a pregnant person to have their TSH monitored?
Yeah, great point, Dr. Feldstein. So if it's a patient who's known hypothyroid and she's on thyroid hormone replacement, like I mentioned, bump up the dose as soon as pregnancy is confirmed with a positive pregnancy test by 25 to 50 micrograms, check it 4 weeks later. And then if it's good, I would check it. I tend to check it every month because I hate medical surprises and find out later rather than sooner that the patient's been undertreated. But if everything's going great, you want to check it at least every trimester. But certainly when there's changes, fluctuation in a month, and then to go back down to the pre-gestational levels postpartum, and then recheck 6 weeks after delivery.
Just, we all are afraid of congenital hypothyroidism. And so I think more testing might be better for this particular issue.
Because it will affect therapy, you're right.
Yeah. And I'm just wondering, I'm trying to think if there were other questions that might have come up. I wanted to make sure I said thank you to our anchor clinic today. And I had my window open and then I forgot. This talk was requested by St. Joseph's Candler Health System Incorporated. I appreciate them. This is such a helpful talk. I know in clinical practice, so many patients struggle with figuring out how to take their thyroid hormone correctly. Let's see, do we have anything else? Let's see what other questions we have. Let's see. Just
And
thinking
appreciate
about
everyone. I was just going to say, appreciate everyone filling out the survey so we can know how to get your feedback so we can know any changes that need to be made.
Yeah. Well, I guess I have a little blurb. So we hope you enjoyed today's session and are interested in attending future sessions, or even your clinic could anchor an educational session. All clinics are welcome to. You get to pick the topic for what's relevant for your particular experience, as well as the date and the time that works for you. The only requirement is that someone from your clinic attends the session. If you are interested in becoming an anchor, then we would love to schedule your session. You can either submit the request on the clinic portal, or you can email Kristen. It's ktalbot@mavenproject.org. And then this is just a reminder that the MAVEN Project offers mentoring for all clinical providers at any point in their career. Some topics that I'm going to reference include people who are new to practice, people who have challenging cases, people who are interested in figuring out ways to prevent burnout or build their teams within their clinic, or even people who are interested in executive coaching. MAVEN has someone for all of that. Also, we do specific mentoring, such as working on EKGs or continuous glucose monitors. I think that's particular. I don't know about you, Dr. Sadur, but I know me included always need help understanding continuous glucose monitors.
Oh, true.
I think we might have gotten all the questions that we've got. Thank you all for participating, and what a really great talk and really good questions. Keep them coming. I'm going to turn off the recording and